Hello, everyone, and thank you for hearing my discussion on the impact of the COVID-19 pandemic on emergency department boarding. First, we'll start by discussing what did we define as emergency department boarding. We took it to mean the time between when the admission order was placed until when the transition for handoff formally occurred with the inpatient team. The impacts of emergency department boarding have already been previously evaluated outside of the pandemic. There has been shown to have increased mortality, increased hospital length of stay, and increased ICU length of stay. And we believe that these factors should be considered when trying to evaluate how best to serve the patients who have been affected by the COVID-19 virus. It was first reported by the World Health Organization on December 31st, 2019. And shortly after that, in January of 2020, we saw our first case here in the United States. Since then, we've had over 28 million cases in the US alone, resulting in over 500,000 deaths. So we had to ask, what is this doing to our emergency department boarding at the University of Alabama at Birmingham? We use a retrospective approach at our single center coordinary system, and we evaluated 32,826 ED admissions. We looked at a pre-COVID era, which we defined as April 2019 to September 2019, and compared that data to a post-COVID era from April 2020 to September 2020. Our primary outcomes were mean boarding time in hours, and we analysed using a Welch's 2-sample t-test. Overall, we can see that compared to the pre-COVID and post-COVID era, there was a significant difference between boarding times. Overall, however, the ED arrivals from the pre-COVID era and post-COVID era did differ, with a decrease in the total number of visits overall. Our results indicated that overall, early in the pandemic, which was defined as April and May, there was a decrease in boarding time, which did show to be statistically significant. Compare this to the mid and late pandemic era, which was July, August, and September. There was an overall increase in our boarding rate in the emergency department at UAB. The decreased ED boarding times were seen in the early pandemic, and this did also correspond with decreased total emergency department visit times. There was an increase in boarding times in late and mid-pandemic in July, August, and September. This is when we initially saw our first peak and increase of COVID patients requiring admission for inpatient treatment. So as previously discussed before, considering the known association between ED boarding times and adverse patient outcomes, it's important to consider these novel trends as the COVID-19 virus remains a national healthcare issue. It can help us monitor ED volumes, especially when it comes to future pandemics. It can help us identify staffing needs as we see these increased boarding times, and can also help us with allocation of location-specific responses. I'd like to thank the rest of the team that helped me with the evaluation of this data, and please feel free to contact me should you have any additional questions that I'm unable to answer today. Thank you again.
Hello, My name is Jared Borrego, and I'm a medical student at the University of New Mexico. Today, I will be presenting Bacteremic Bouncebacks, Reconsider Discharging that Urinary Tract Infection. This was an evaluation of 72-hour returns among patients who had positive blood cultures at their initial visit. Before I begin, I would like to acknowledge my co-authors and thank them for their help throughout this project. Myself and my co-authors have nothing to disclose. Recognizing early signs and symptoms of bacteremia and sepsis remains a critical skill in the everyday practice of emergency medicine. However, the gold standard diagnostic test, blood cultures, take time to process and are often unavailable for upwards of 24 hours, resulting in many potentially bacteremic patients being discharged from the emergency department after their initial screening exam. This creates a potential lapse in care of a life-threatening medical condition, with misdiagnosis increasing both morbidity and mortality in this population. Screening tools like the Quick Sequential Organ Function Assessment, or QSOFA, and the Systemic Inflammatory Response Syndrome, or SIRS criteria, are available to help with risk stratification, but are verified on inpatient metrics and have limited efficacy in the emergency department setting. To address these concerns, this study aims to find baseline characteristics of patients who are called to return to the emergency department after positive blood cultures at their initial visit. Our goals of identifying populations, clinical presentations, and risk factors, in addition to objective laboratory tests among these patients, hope to expose gaps of knowledge and improve quality of care and patient safety. This was a single-center study conducted at the University of New Mexico Hospital. An inquiry of all patients who presented the ED between January 2018 and September 2019 were screened for patients who had blood cultures drawn at their initial visit with subsequent return to the emergency department within 72 hours. Patients were included in this study if they had both positive cultures at initial visit and returned within 72 hours. Patients in this study had an average age of 53, were mostly male, identified as Hispanic or Latino. They were white and spoke English. A large proportion of this study population were insured by either Medicare or Medicaid, with individuals without insurance also making up a sizable portion of subjects. The most common comorbidities identified in this study included hypertension and diabetes, followed closely by COPD. Also of note were 2 patients with indwelling peripherally inserted central catheters, or PICCs, as well as 2 tunnel dialysis catheters. Chief complaints at patient's initial visit were most commonly fever, extremity swelling and/or pain, as well as flank pain. ED diagnoses from this initial visit were mostly UTI and/or pyelonephritis, nonspecific illnesses such as viral syndromes, myalgias, and fatigue, as well as various locations of skin and soft tissue infections representing abscesses and cellulitis. Overall, 81.5% of patients were contacted by the ED to return due to positive blood cultures, with the majority of patients returning with a chief complaint mentioning abnormal lab result or positive cultures at their return visit. All of these patients were admitted to the hospital for further treatment of their bacteremia. 1 patient required intensive care unit level of care, and 1 unfortunately died during their stay. At index visit, 35.7% of patients had a QSOFA score greater than 2, the cutoff designed for that stratification tool. Half of patients met SIRS criteria at this visit. The number of patients meeting cutoffs for both of these scores decreased at return visit, with the number of patients meeting 0 criteria markedly increasing across visits. The most common organisms isolated from index blood cultures included Streptococcus species, including 2 strep viridans, as well as 2 strep pyogenes, E. coli, as well as Staphylococcus species, including Staph aureus and Staph epidermidis. At final discharge from the hospital following return visit, 85.7% of patients had diagnoses mentioning sepsis or bacteremia. Among the 13 diagnoses that mentioned a source of infection, 46.2% mentioned UTI and/or pyelonephritis, followed by 23.1% mentioning an iatrogenic cause, such as a PICC line or tunnel dialysis catheter. 15.1% of patients had a discharge diagnosis of sepsis due to endocarditis. The study, of course, had its limitations, being a single-center study with a small number of patients. Additionally, UNM Hospital is adjacent to several other large hospital systems, increasing the possibility that patients may have presented to a different ED for treatment. This study had no comparison group to infer statistical differences from. A potentially larger study with a control group of patients who did not have positive cultures could provide an important comparison group in the future. Overall, patients in this study presented with a wide variety of chief complaints. However, it is important to acknowledge the large proportion of patients with genitourinary and iatrogenic sources of bacteremia. Having these patients return upon eventual receipt of positive blood cultures increases both morbidity and mortality by delaying treatment of a bloodstream infection. Our main takeaway today is that patients with genitourinary complaints, or those with indwelling PICC lines or tunnel dialysis catheters, warrant increased caution and consideration of disposition options when it comes time to discharge from the department. This is especially true if there is concern for bacteremia.
Hi, everybody. My name is Tanya Gergenrath. I am an administrative fellow at the University of Massachusetts in Worcester, and welcome to my virtual presentation today on the effect of the COVID-19 pandemic on patient satisfaction scores in the emergency department. I have no financial disclosures at all to put on this slide. So let's talk about patient satisfaction scores. Likely for anyone listening to this talk, we all know that patient satisfaction scores are one of the key metrics used by many hospitals to evaluate the care delivery in the emergency department. It's important for a whole host of reasons that we'll talk about more later. But one of them that I think is really interesting is that the impression that a patient has of their stay in the emergency department can have a major impact on their impression of their entire stay in the hospital, including their time as an inpatient. This cartoon created quite a stir amongst my colleagues about who got it and who didn't. So I ultimately left it in. You guys can decide amongst yourselves looking at it later. So why else care about patient satisfaction? There's lots of reasons. There have been studies that have shown that patient outcomes, as well as medication compliance, can be affected by patients' impression of their hospital stay. It can have an effect on lawsuits. And even putting aside those things that have been studied before, we want our patients to feel like they've been treated with dignity and respect while they're in the hospital. And quite simply, when they're happy, we're happy. Our jobs are more pleasant when patients are satisfied with the care that they're receiving. It's a little bit easier for us to do our job. So how to improve scores? This is probably something that anyone who's particularly in administration has thought about before. But what I think probably no one has thought before, no one has had an aha moment where they suddenly thought, I know, how about a deadly global pandemic? I bet that'll do it. Probably no one would expect that, and neither did we. But that is what we observed, which is what led us to do this study that we did. So this was a retrospective observational investigation. We analyzed Press-Ganey satisfaction scores from 2 different emergency departments, and we looked at basically the likelihood of a patient to recommend our ER to others. Our 2 sites were a large tertiary care center with 100,000 annual visits. That's our main academic center. And then site 2 was a community ED just about 1 mile down the road, very different setting, 43,000 annual ED visits. So we compared the percent top box responses, meaning people who positively responded to their likelihood to recommend our hospital during the COVID-19 pandemic. And we compared that to the corresponding time period from the previous year. And for our dates, we simply used our governor issued emergency order, which went from March 10th to July 2nd of 2020. Unbelievable that it was a year ago. And these were our results. So for each of our sites, and then in the combined setting, there was a significant improvement in the number of people, percent of people who said that they would be likely to recommend our hospital. The p-value for each of these was less than 0.05. So we were able to conclude that, in fact, patient satisfaction scores in the ED improved in a significant way during the coronavirus pandemic, which was interesting. So yay, wonderful. That's great news. But then, of course, we were left wondering, well, why in the world would that be? So one of the limitations of our study was that it wasn't designed to determine the causal factors for this, why we may have seen this improvement, but it led to some very interesting conversations about what sorts of things that came along with the pandemic may have caused patients to have improved experiences. The possible contributors that we discussed, many hospitals, including ours, both of these sites had elimination of hallway beds during coronavirus. There were decreased ED volumes, which is something that we experienced at our hospitals, and I know was experienced at hospitals across the country. There was decreased boarding, so patients were getting their rooms faster, and there was more provider face time. Because of decreased ED volumes, providers were able to spend more time with their patients one-on-one. The other thing that came up during the coronavirus pandemic, which I'm sure you all experienced, was an increased public appreciation for healthcare workers. So it is hard to know, but interesting to look into whether or not that may have played a role as well. And so this sets us up for future studies when we can maybe look into what the causal factors were for increased patient satisfaction scores. So what's going to happen when this chalk washes away, and what can we do to make demonstrable differences to our patient experience in the ED? And that was our study. So thank you so much. These are my references.
Thank you to SAEM for giving us the opportunity to present our research titled Investigating the Emergency Department Diagnostic Process, Insights from the Frontline Providers. We have no conflicts of interest to disclose. The emergency department is prone to diagnostic errors because decision-making occurs in time and information-constrained settings in patients whose illness has not completely evolved. The diagnostic process is a highly complex cognitive task that is poorly understood and investigated. This study is a part of a parent grant which uses systems engineering approach to study a complex process such as the diagnostic decision-making process. Aim 1 of the grant is to understand the ED diagnostic process. Aim 2 is to co-design interventions to improve diagnosis. And Aim 3 is to implement and study the impact of interventions on diagnostic errors. The study is a part of Aim 1, where we are going to study the diagnostic process, where we are going to perform stakeholder interviews. The other two aspects of this study could not be performed because of COVID-related constraints. In this study, we conducted interviews with pediatric and adult emergency providers to identify vulnerabilities and opportunities to enhance diagnostic safety, and then eventually design interventions and improve diagnostic safety. As a part of our methods, we first piloted and iteratively designed a provider interview guide. We then recruited participants and consented them electronically. We then conducted a 1-hour interview held via Zoom, and these interviews were recorded and transcribed verbatim. We recorded the participant demographics, mainly in the years of emergency department experience, their training, and the number of shifts that they do. Following which, we showed them an ED patient flow map and asked them to consider the diagnostic process in the context of a patient with an undifferentiated illness, such as abdominal pain, fever, or headache. This is the ED flow map where we showed them the events that happen to the patient as they come to the ED prior to disposition. When they arrive to the ED, where they are screened and triaged, placed in a treatment room, history and physical examination is performed, orders are placed, ongoing treatment and investigations are performed, reassessment, and a final disposition is done. Following which, we ask them specific questions regarding the process of information gathering, information integration, and diagnostic decision making. We also analyze their responses in the form of diagnostic reasoning frameworks, such as distributed cognition framework and the dual process thinking framework, which includes fast thinking and slow thinking. We also identified influence of interactions, such as their interactions with consultants, identify patient characteristics that can influence the diagnostic process, and their interactions with trainees. Subsequently, we also asked them questions related to systems factors that could impact the diagnostic process, such as technology, specifically electronic health records, the ED volume, and patient boarding, and other aspects of patient care. To date, we have conducted 17 interview sessions, 4 attending physicians, of which 3 have been pediatric emergency and 1 general emergency physician, 2 trainees, and 11 nurses, 6 pediatric and 5 general EM nurses. Our results show that the physicians and nurses both use both dual process theory and distributed cognition in the diagnostic process. Typically, in the dual process, there are aspects of fast thinking that are often incorporated in the diagnostic process. Often, they embark on a diagnostic journey and perform broad evaluation just by the history provided to them by the residents or that they obtain from the notes. The process is different if they are being presented a case by a resident versus when they go and evaluate the patients themselves. However, the overall goal is not to miss emergent conditions, and hence the initial thought process is much more broad. They also use aspects of distributed cognition, such as the use of electronic health records for notes and use of those for prior visits. Not often, but occasionally, they also use nursing notes and other resources such as UpToDate to help them in the diagnostic process. Differently, nurses also use dual process aspects of fast thinking, where they use pattern recognition as an integral part of their evaluation. And often it is dichotomous, where they try to categorize patients as severe versus non-severe illness. They also use aspects of distributed cognition, but more often it is with their better rapport with patients, where they get aspects of the history and physical, which are often not obtained by the physician team. They also mentioned they often have much better communication both with the patients and the caregivers. However, they do not feel involved unless they are specifically sought in the diagnostic process. Both the nurses and the physicians gave us ideas about how to improve the diagnostic reasoning process by providing ideas about modification to the physical ED space, such as performance of huddles in patients with a broad differential diagnosis. They also insisted that we need to integrate both nurses and trainees throughout the diagnostic process. Most importantly, they felt that we need to empower the nurses in the patient communication of the diagnosis, because they often have a better and a prolonged relationship with patients and caregivers even after the physicians have left the room. In conclusion, interviews with frontline providers can shed light on other unexplored factors involving the ED diagnostic decision-making process. We can help identify contributory factors that can predispose to diagnostic errors, and there are opportunities for co-designing meaningful interventions. Our next steps include to recruit and conduct more interviews with additional groups, including trainees and residents, advanced practice providers, consultants, and patients and caregivers. Following this, we are going to perform and conduct co-designing of interventions with the same stakeholder groups, and eventually we're going to implement and test these interventions in order to mitigate diagnostic errors. In conclusion, I want to thank my collaborators and also SAEM for giving us the opportunity to present our research.
The study is a multi-center evaluation of the differences in procedural practice amongst emergency medicine physicians at tertiary care centers versus at community care centers. We have no conflicts of interest to report. These sites were chosen because of differences that exist, including the volume of patients seen, the acuity, and available resources, and the presence of other providers who may compete for procedures with attendings, including consultants, physician assistants, nurse practitioners, and residents. The purpose of the study is to determine the impact of working at either a tertiary academic center on the number of procedures performed by attending physicians as compared to their counterparts working at non-academic community sites. This was a multi-site retrospective study conducted over 22 months at 4 academic tertiary hospitals and 6 non-academic community hospitals. The procedures of focus include tracheal intubations, central venous line insertion, tube thoracostomy, lumbar puncture, point-of-care ultrasound fast examination, and point-of-care ultrasound-guided peripheral intravenous line placement. Participants include 206 attending physicians at academic tertiary sites and 225 physicians at non-academic community sites. Attribution of a procedure was solely determined by documentation within the electronic medical record. An independent samples t-test was used to measure statistical significance between both groups and procedures performed. Here are some of the results listed. The conclusions of the study show attendings at community sites had a statistically significant higher number of intubations and tube thoracotomies per year. However, attendings at tertiary sites had a statistically significant higher number of fast examinations and ultrasound-guided IV placements per year. However, neither group had significant differences in lumbar punctures, or central venous catheters. Now, some limitations of this study include its retrospective nature and determination of attending performing procedures solely determined by procedure notes and depending on the EMR. Hospitals and health systems may consider providing additional training opportunities to attending physicians at each type of institution based on the information presented to ensure maintenance of procedural competency.
Hi everyone, my name is Rohit Sengal, and I'm an administrative fellow in the Department of Emergency Medicine at Yale University. So today, I'm going to discuss a project we started right before the pandemic, examining opioid prescribing in the context of the policies and nudges implemented within our health system. So many of you already know about the opioid epidemic, and there have been a wide variety of interventions, required classes, defaults, nudges, to try to decrease clinician prescribing. But less is known about which interventions work the best. Some are active, where you interact with the EMR, like pop-ups or two-factor authentication, and others are passive, such as looking up the PDMP, getting a report card from the Department of Public Health, and system defaults. So what we did is we looked at all ED discharges across 3 emergency departments that in aggregate see 200,000 patients annually, over a 3-year period from 2017 to the end of 2019. And the primary outcome was opioid prescriptions per 100 ED visits, and the secondary outcome was morphine milligram equivalents per 100 ED visits. We also performed a secondary analysis looking at alternatives to opioids to see if those increased. All these analyses adjusted for an underlying secular trend in opioid prescribing, as well as demographic factors and site. The 4 interventions we examined from oldest to newest were setting a 12-pill default, where the maximum number of pills when you write a opioid prescription was 12, unless you manually changed it. Two-factor authentication, also known as electronic prescribing of controlled substances, so EPCS. And what this means is when you write a prescription for an opioid or a controlled substance, you get a message on your phone to confirm it, and you have to retype in your password or a code. A pop-up or best practice advisory, which is essentially a clinical decision tool, and then an 8-pill default, so going from that 12-pill default to an 8-pill default. So here are the results. So the y-axis is prescriptions per 100 ED visits, the y-axis is time, and the vertical lines are when EPCS and pop-ups went into effect. This blue line is opioid prescriptions, and there's a statistically significant decrease in opioid prescriptions for both of these interventions. However, it was greater for the clinical decision tool, the BPA, where we saw a decrease of 2 prescriptions per 100 ED visits. So this graph is the same graph as before, but what's been added is the purple line, which is the alternatives to opioids. And what you can see is that there's a statistically significant increase in the alternatives, most specifically after the pop-up. And so we had hypothesized that clinicians would not like the multi-step process of two-factor authentication, and that may itself be a barrier and drive down opioid prescription rates. However, the effect is much greater for the BPA. So to kind of look a little closer at this, we looked at the BPA itself, and here's what you see. And it prompts clinicians to examine the opioid risk score and gives them a link to access the PDMP. Now, we don't know how many clinicians actually interacted with the PDMP, but maybe just putting this in front of clinicians may have been enough to make them think about doing an alternative to opioid. When we look at the secondary analysis, or secondary outcome, we see similar results with MME per 100 ED visits, where we saw statistically significant decreases at both the 8-pill and 12-pill defaults. And this makes sense because defaults are passive and rarely do people change the default. So overall, BPA and pill defaults were the most effective at reducing opioid prescribing. However, these work in very different ways. Defaults are passive and impose no extra cognitive burden on the clinician, unlike pop-ups, which have a bad reputation. So future interventions need to look for ways to implement changes that don't impede workflow, but can still have the desired effects. And so with that, thank you to the large team that has been part of this, helping me analyze the massive data set and bounce questions off of. I'm happy to take questions. Thanks.
Hi everyone, my name is Smita Heslin, and I'm from Stony Brook University Hospital in Stony Brook, Long Island, New York. Our project is on the specimen mislabeling of licensed practical nurses in emergency department team triage. Background. Emergency departments, EDs, face crowding and resource limitations daily, and emergency registered nurses, RNs, often have many patients and a significant number of tasks to perform. Team triage can be used to expedite patient workups and decrease the workload of downstream providers. In our department, we utilize licensed practical nurses, LPNs, to place IVs and draw labs as part of our team triage team. Objective. In this study, we looked at the specimen mislabeling rate of LPNs as well as their productivity while working in this team triage system. Methods. This study took place in a large academic medical center in New York with nearly 100,000 annual patient visits. We studied adult patients who went through team triage between January 1st to January 31st, 2020, from 11 a.m. to 11 p.m. For patients getting blood draws by an LPN, we studied the total number of IVs placed, number of tubes of blood specimen drawn, and how many specimens were mislabeled. Our results. In the 1-month time period we studied, 372 hours of LPN coverage was provided to the team triage process. There were 1,075 patients who had labs drawn by an LPN. For the patients who went through team triage and had lab work drawn by an LPN, the average age was 46 years old. Average ESI was 3. 62% were female, and 78% were discharged from the emergency department. A total of 1,017 IVs, which is 2.7 IVs per hour, were placed by LPNs, and 2,558 tubes of blood, which is 6.9 tubes per hour, were drawn by LPNs. There were 0 specimens mislabeled by LPNs. Our conclusion. LPNs were highly productive in the team triage process and had 0 mislabeling errors. With EDs becoming more crowded and RNs having a significant number of tasks to perform, LPNs can help RNs with placing IVs and blood draws, which can help with ED throughput and flow. Thank you so much.
My name is Moin Enayati, and it is my pleasure to present our recent findings regarding the iterative refinement of electronic triggers to improve the identification of diagnosis errors. This work was performed in a close collaboration between an interdisciplinary team of researchers, physicians, and experts, and the authors do not have any conflict of interest to report. As you might know, diagnosis errors have received a lot of attention due to their impact on the patient's safety. About 30% of malpractice claims and more than 8% of adverse events in the medicine are related to diagnosis errors, yet most are never reported. Researchers reported a 15% rate of diagnosis error in clinical medicine, 5% of adult misdiagnosis annually in outpatient care, and about 15 to 30% in the context of emergency department. In fact, diagnostic decision-making, especially in the ED, is a highly complex cognitive process involving uncertainty and is susceptible to errors. This results in approximately 7 million harmful errors out of the total of 139 million annual ED visits in the US, making diagnostic safety a high priority for ED-related research. There is an urgent need to design, implement, and develop novel models to identify and reduce risk related to the diagnostic process in the ED. According to the literature, using electronic triggers to identify records of patients with certain patterns of care has been useful for screening diagnostic errors. 3 EHR-based e-triggers were selected in the IDEAL grant after reviewing the literature on current triggers, surveying medical directors, and using Delphi process to identify ED encounters with potential diagnostic errors. These triggers monitor the unscheduled visit within 10 days, resulting in the admission, care escalation to ICU within 24 hours, or death in the ED or within 24 hours of the ED departure. E-triggers are objective means to screen and study errors and missed opportunities to make more accurate diagnosis. However, they suffer from suboptimal yield and low positive predictive value due to the lack of a complete clinical care context. Our objective in this pilot project was to use an iterative refinement process to study and improve the performance of this e-trigger by incorporating ED physicians' reviews. We designed an iterative agile process and asked trained ED physicians to review the diagnosis and categorize trigger-positive records into those with and without error by employing a standardized screening tool called SaferDX. Reviewers' insights into those charts were used in the return iterative cycle to identify variables that can be added to the e-trigger SQL query, further refine the process of screening. For example, our physician reviewers were not happy about T3 because it contains many inevitable death cases that are not related to any error, such as massive head bleed or arrival in cardiac arrest. Similarly, T2 contains many patients who required obvious ICU admission from the beginning, such as a patient with massive chest trauma who went to the ICU directly from the ED, with managements as expected. There is no escalation in health conditions as we defined. As a solution, ED physicians proposed incorporating rapid response time activation as an additional screening criterion to improve the performance of T2. In fact, most patients that went to the floor and then to the ICU have an RRT activation or code blue activation. So we focused on T2 and computed its positive predictive value before and after the proposed refinement. We explored 1 month of EHR data covering more than 6,000 patient encounters at the large academic ED. Original e-trigger query identified 71 encounters as trigger positive. Initial chart reviews revealed 6 cases of diagnosis error with a PPV value of 8.5%. Adding RRT improved the PPV to 28.6% and reduced the physician burden of reviewing the charts by 80%, which is equivalent to 14 hours of workload reduction. To conclude, iterative refinement by incorporating frontline clinicians' perspective improves the performance of e-triggers and reduces the burden of manual review of patient records. Further testing on larger and diverse data sets is needed to enhance the generalizability and feasibility of the care escalation e-triggers. We also plan to reinforce multiple inclusion-exclusion criteria to the queries to ensure irrelevant information is not affecting our selections. Building on that, and in the future, we will use machine learning approaches with patient and frontline provider factors to develop a real-time dynamic trigger-based diagnostic error risk prediction tool. This will inform clinicians of potential risk based on the patient's EHR records that could be preventable or addressed through an appropriate intervention. Here is the list of citations for reference. And thank you all so much for your attention. Please feel free to contact me or any other collaborators in this project for any questions.
Hi, everyone, and thank you for joining. This presentation is the implementation of a novel emergency department discharge center. at the Long Island Jewish Emergency Department, presented by Richard Tang. The Long Island Jewish Medical Center, ER, is an urban academic tertiary care emergency department that serves vulnerable patient populations and is the largest ER by volume in Northwell Health, the largest health system in the Northeast. It serves a diverse patient population with many non-English speakers represented. Our discharge center project grew from a recognition that we were having difficulty providing the proper discharge instructions and follow-up appointment directions for our patients to ensure their successful departure from and continued care after their ER visit. This is a common issue across ERs, with providers frequently strapped for time and often having limited bandwidth to ensure a thorough discharge process. Our solution for this issue was to take these tasks out of the ER provider's hands, especially in more involved cases with patients with high social risk factors or limited medical knowledge. Patients are referred to the discharge center by the ED provider, who identifies, treat, and release patients who are at highest needs for its services. The discharge center itself is composed of a staff of 3 individuals. First is the discharge center nurse, who explains and reinforces discharge instructions with patients. Then there are 2 patient access coordinators who are in charge of setting up follow-up appointments and outpatient services, such as home health, when indicated. In some cases, patients are referred to multiple specialty follow-up appointments. These resulted in 1,753 referrals, 1,584 touch points, 1,218 appointments, and finally 1,051 callbacks were made in total from August 2020 to February 2021. You can see that after the initial drive to utilize the discharge center, there was a brief drop followed immediately by a steady upward trend in referrals and appointments. The proportion of all treat and release ER patients provided specialty follow-ups through the discharge center has steadily increased since its inception, from 1.6% to 6.5%. The most common specialty appointments can be seen here that were made through the discharge center, and in increasing order, they are spine, dermatology, ENT, urology, cardiology, OBGYN, orthopedics, internal medicine, and finally, the most common one, gastroenterology. There still remains a great deal of data that we are trying to collect in order to determine the true benefit of the discharge center. Preliminary data suggests that there is no statistically significant difference between median length of stay and treat and release population versus the discharge center population. However, as the throughput process for the discharge center continues to become more refined, we may even find a small benefit for patients who can be discharged who would otherwise need to wait for ER providers to provide similar resources. The remaining metrics have been challenging to measure due to technical difficulties, particularly in trying to assess the actual appointment completion rate. As the discharge center continues to mature, so will our data collection efforts. And finally, one exciting opportunity for expansion of the discharge lounge is in using it to address social determinants of health by obtaining information about individual patients' needs, such as housing, education, economic stability, and connecting them with outpatient resources for a better holistic management plan. In conclusion, making appointments in real time through the discharge center has the potential to increase patient adherence to follow-up without increasing length of stay significantly. Analysis of referrals made from the ER discharge lounge can provide insight into the long-term health needs of vulnerable patient populations in urban areas. This framework has the potential to reduce burden on ERs by reducing repeat ER visits, improving patient experience, and promoting successful continuity of health management. We are confident that future investigations into the outcomes of the discharge center will continue to demonstrate further value in it. Thank you very much for your time.
Hello, my name is Namal Senavaratna, and I'm a second-year medical student at the Albert Einstein College of Medicine. Today, I will be presenting a study that utilized in situ simulation to evaluate latent safety threats in airway management across multiple institutions. In the spring of 2020, New York City was the epicenter of the COVID-19 crisis nationally. The hospitals in our medical system were particularly hard hit, As the numbers slowly began to decrease, our individual departments and hospitals identified room for improvement in COVID-19 airway management, in particular the areas of infection control, equipment, and communication during intubation. In order to address these issues, we decided to apply in situ simulation as a quality improvement tool. However, instead of studying just one hospital, we decided to collaborate with 5 different institutions in the Bronx and Westchester County affiliated with our health system and medical school. We hypothesized that there would be similar latent safety threats across various institutions despite how different they are, academic versus community and inner city versus suburban. We gathered a collaborative of healthcare workers across the institutions, mapped out our objectives, and performed standardized debriefer training across all sites. Our presentation summarizes findings from our initial cycle of simulations, which was performed from June through August. This was a low-fidelity in situ simulation performed in the emergency department with multidisciplinary teams. As you can see on the left, we streamlined our setup to be easily stored and cleaned, and our simulation required no extraneous staff. Please see our reference Jaffrey et al. For details on safety considerations for in situ simulation in COVID settings. Our scenario was the emergency airway management of a patient with COVID-19 associated respiratory failure with worsening hypoxia despite BiPAP, thus prompting participants to consider intubation. Following the scenario, we conducted a debrief utilizing a systems focus adapted from Dubé et al., as you can see in the figure on the right. We focus on systems-based latent safety threats rather than individual learner objectives, and when time permitted, solutions. The entire simulation and debrief were completed in 15 minutes. Ultimately, 32 simulations were completed. There were a total of 158 participants, including attendings, house staff, APPs, nurses, and other personnel. A total of 232 latent safety threats were identified and categorized into infection control, equipment, and communication. Here we illustrate the distribution of the perceived latent safety threats by institution. Whereas Jacobi and the Children's Hospital had even numbers of LSTs in each category, the Weiler and White Plains sites demonstrated more equipment-related issues than the others. We did, however, appreciate common themes in each category. For example, in the category of infection control, we noticed strong overlap in threats. This table illustrates the threats we came across most frequently in the simulations as a tally. At almost every site, individuals entered the room without PPE, and there was a lot of unnecessary traffic in and out of the rooms. There were also issues regarding where gowns were kept and ease of access. Specific equipment-related LSTs and methods for equipment storage differed by site. However, almost every site identified issues with viral filters not being readily available or restocked. Communication latent safety threats were very similar among sites. These included lack of clear role designation, closed-loop communication, designated runner, or huddle. There were notable similarities between the 5 hospitals. Lack of easy access to viral filters was a common theme and among the first items addressed even during the first cycle. Before COVID-19, viral filters were rarely used, so it's unsurprising that they were not stored in the airway carts and bags until the LST was identified. We also observed differences in LSTs. Some of these may reflect differences in policy and workflow. For example, laundered versus disposable gowns, airway carts versus portable airway bags, and varying processes and people responsible for restocking. Staffing was also different among sites. Nursing ratios varied by site and clinical load that shift. Team makeup was also different, with participation of APPs in community sites and house staff in academic ones. One limitation is that we relied on standardized debrief forms rather than use AV recording to measure LSTs. This was in order to minimize equipment and staffing required to conduct the study, as we were performing these often in closed COVID units. Although all debriefers underwent standardized training and practice with a debriefing tool, we acknowledge that latent safety threats captured this way can be subjective. Each site convened its own QI team to review and prioritize LSTs and interventions. Generally, sites address equipment and infection control issues first and are currently performing simulations for Cycle 2, with the exception of White Plains, which is on an accelerated timetable. Please see that separate presentation. What's been interesting and fruitful in our monthly meetings as a collaborative has been our shared progress and similar challenges. I'd like to give special thanks to my mentors, Dr. Farouk Jaffrey and Dr. Christina Yang, and all of those involved with this project. Thank you for listening, and please ask any questions.
Hello, my name is Rebecca Goodwin. I'm a PGY4 EM/IM resident at Virginia Commonwealth University Hospital. I'd like to share with you our experience regarding non-hospitalized COVID-19 positive patients and the model program we created to provide follow-up and monitoring of these patients. I have no disclosures. In order to illustrate this program, let's use an analogy. Now, we all may be watching a little bit more TV than usual during the pandemic, so I'll allude to a show you may be familiar with, The Deadliest Catch. As we've weathered the storm of this pandemic, emergency medicine providers find themselves faced with difficult choices every shift. We have to decide who is sick enough to stay, who is highest risk of decompensation, if they're going to crump today or tomorrow, if ever, or whether to admit these patients just in case they get worse. Especially with overcrowded hospitals and resources that are stretched thin, how do we handle a stable patient who is high risk for adverse outcomes? We are charged with forecasting the future of these patients. We are tasked to catch those with the deadliest course. Oftentimes, we know that a particular patient can go home at the time of their visit, but we're uncomfortable by their lack of follow-up because of their high-risk features. Especially as so many clinics were closed during the initial months of the pandemic, and at VCU, our population tends to reflect the uninsured and those less likely to have established follow-up options. We needed a stopgap. To create a safety net, VCU instituted a system of remote home oxygen monitoring as a way to track those at highest risk for adverse outcomes and catch decompensation before it took lives. And what did we call this program? Rom-com, because we're ER doctors, and what do we love more than catching deadly diseases early? It's like the love between Alaskan fishermen and their king crabs. It stands for Remote Oxygen Monitoring for COVID-19 Outpatient Management. In this program, we targeted high-risk COVID-19 positive patients, those with high-risk features identified by the CDC, such as obesity, coronary disease, immunosuppression, etc., and we offered them enrollment in this program. They were enrolled either in the emergency department at the time of their visit or over the phone during standard calls informing them of their COVID status. Enrolled patients were then given a pulse oximeter. A provider, often a PA or NP, would then call them on post-ED visit days 2, 4, 7, 10, and 14, and were asked about their heart rate, oxygenation both at rest and with exertion, and their symptoms. If a patient was found to be hypoxic, which we defined as less than 90% at rest or with exertion, or if they were complaining of worsening symptoms, they were advised to return to the emergency department for further evaluation. This monitored rom-com group was then compared to the unmonitored patients before the program started. Overall, our intention was to monitor high-risk patients at home, identify concerning symptoms or silent hypoxia early, and to encourage return at first signs of decompensation. In the beginning of the pandemic, data seemed to suggest that early intervention on silent hypoxia could drastically change outcomes. So this was our way of creating a safety net to try and catch decompensating patients early. Here is the look at the first data that we pulled to the surface. We evaluated a total of 261 patients, 76 unmonitored patients, and 185 enrolled patients. Our intervention was the provided pulse oximeters and the 5 follow-up phone calls. We then compared those patients' outcomes to the COVID-19 positive individuals who did not have that resource provided to them. Specifically, we were interested in knowing if this outreach helped decrease the number of return visits, the need for hospitalization, or death. And we initially looked at outcomes 30 days out from their visit. So what did our initial haul of data show? Well, first I'll note that the demographics between the groups, age, gender, race, insurance status, and risk factors were similar. As for our initial metrics, return ED visits and admission rates, there was not a statistical difference. The p-values were 0.51 and 1 respectively. However, this trend does seem to favor intervention to decrease admissions and that more people were encouraged to seek follow-up in the monitored group. And did we prevent anyone from falling overboard? Currently, the 30-day mortality data shows no statistical difference. However, there does appear to be a positive trend suggesting that our program may be on the right path. There were 2 documented deaths in the unmonitored group, and so far, none in the rom-com group. but this has not yet reached statistical significance. We did, however, note a statistical significant decrease in the number of intubations for those enrolled in the program. Currently, there were 5 intubations for the unmonitored program and none in the ROMCOM group. This may be due to the increased number of return visits, thus prompting intervention early and decreasing the need for invasive airways. In the next few months, we will continue our program and data collection. I'm encouraged by the preliminary data, and I'm curious to see how the data evolves as we follow up on a greater number of people. So far, our data supports that close monitoring and early intervention for discharged COVID-19 positive patients has the potential to significantly impact patient outcomes, such as the decreased need for intubation. And overall, this program demonstrates a feasible model for how to provide such follow-up for those high-risk individuals in the midst of this pandemic. I thank you all for your time and attention and wish you all the best of luck out there on the high seas. Thank you.
Hello, this is Timothy Barbosa. I'm a senior resident of emergency medicine at McGovern Medical School at UT Health in Houston. This presentation will cover a research project that we conducted to evaluate physician efficiency and its relationship with medical errors. We appreciate this opportunity to share our findings. My co-investigators, Dr. Rogg and Dr. Hoot, are part of our emergency medicine faculty at McGovern Medical School. We have no financial conflicts of interest to disclose related to this research. Medical errors have been shown to create significant risk to patient safety. One key goal of ED administration should be to optimize patient flow while maintaining quality of care. ED crowding and the need for revenue generation create pressure for physicians to operate as efficiently as possible. However, increasing efficiency results in increased cognitive load and requires frequent task switching. Our review of existing literature showed little to no data regarding the relationship between physician efficiency and the risk of medical errors. The primary objective of our study was to assess the relationship between medical errors and physician efficiency, defined in terms of patients seen per hour and RVUs generated per hour. The secondary objectives were to assess whether physician demographics, such as age, gender, and years of experience after board certification, were associated with the risk of medical errors. Our emergency medicine faculty created and implemented a QA process based on a culture of peer review and an associated informatics tool called the Medical Incident Reporting System, or MERS. Additional details provided in the reference below. Implemented in 2009 and owned by the Emergency Medicine Service Line, this process is based on the principles of voluntary and timely reporting, with emphasis on responding to incidents in a non-punitive manner. Its core focus is improving system safety and quality of care. MERS exists in parallel with the quality review processes that exist at both hospitals where we provide care. It does not replace those processes. However, we believe that successful internal quality improvement has diminished the need for hospital-based review. Quality concerns are referred into MERS via numerous sources to help ensure comprehensive capture. Each submission follows a standardized process for review and adjudication by the QA committee involving 5 or more board-certified emergency physicians. Cases warranting further discussion are presented at conference for faculty and resident consideration. In concluding each referral, the committee scores each case and determines whether an error occurred. We performed a retrospective analysis at our academic urban adult ED from 2016 to 2019. The site operates as a busy level 1 trauma center for a population of roughly 10 million people. We included all faculty physicians who worked at least 400 hours in the adult ED during the study period. Physician efficiency may occasionally become limited by either low demand for emergency care or high inpatient boarding, but these conditions are not common in our practice environment. We attempted to mitigate this potential issue by including physicians with at least 400 duty hours. The primary outcome measure for this research was the rate of adjudicated errors for each physician, where an error was determined to have occurred through our quality assurance process. These data were obtained from the MERS database. The total number of errors per physician was normalized using the total number of patients seen by that physician, resulting in a rate. The covariates used to represent clinical efficiency were patients seen per hour and RVUs generated per hour. These data were obtained from our billing database. We also obtained covariates for physician age, gender, and years of clinical experience since board certification. Numeric covariates were discretized into quantiles. We divided age, patients per hour, and RVUs per hour into quartiles. We divided years of clinical experience into ranges of less than 2, from 2 to 10, and greater than 10 years. These thresholds were intended to divide our population into recent graduates, physicians with some experience, and seasoned physicians. Of the 39 physicians included, 14 were female and 25 were male. Their ages ranged from 28 to 63 years. Their experience ranged from board eligible to 28 years since board certification. Median and interquartile values are shown for provider productivity. Median values reflect 1,107 duty hours, 2.7 patients per hour, and 7.7 RVUs per hour. The overall rate of errors in our study was relatively low, with a median of 1.6 and a mean of 1.7 errors per 1,000 patients seen. Our analysis showed a significant association between rate of medical errors and RVUs generated per hour, with the lowest quartile of RVUs per hour associated with the highest error rate, 2.2 errors per 1,000 patients seen. The rate of medical errors was relatively stable for the other three quartiles, at 1.3, 1.9, and 1.3 errors per 1,000 patients, respectively. We did not identify a significant relationship between the rate of medical errors and patients seen per hour. Our analysis showed a significant association between rate of medical errors and physician age, where the lowest quartile of age was associated with the highest error rate, 2.3 errors per 1,000 patients seen. The rate of medical errors was relatively stable for the other three quartiles at 1.3, 1.5, and 1.6 errors per 1,000 patients, respectively. We did not identify significant relationships between gender or years of clinical experience and error rates. We found that the quartile physicians with the slowest rate of RVU generation per hour and the youngest quartile physicians had the highest rate of adjudicated medical errors in our study. Our study has two limitations. First, not all medical errors may have been caught by our QA process. Second, the results of our single-site study may not generalize to other environments. These results may guide targeted training and education in order to create a system that aids safer medical decision-making.